If the organs are not involved, we usually manage the patient with non-steroidals, as needed, antimalarials, which are disease-modifying, low-dose corticosteroids, and if we cannot keep the patient below about 10 milligrams of prednisone, or if there's another indication, we often use an immune suppressive, and in those without organ-threatening disease, it's usually azathioprine or methotrexate. For non-organ-threatening disease, we often, before we go to medication, look at other measures. The measures, in addition to medication, include physical measures, counseling, and surgery. The physical measures include telling patients to avoid ultraviolet light, to do stretching or isometrics as opposed to isotonic exercise. Counseling is that the head bone is connected to the immune bone, and if we can alleviate their anxiety and educate them about the disease with literature from lupus advocacy groups or websites or blogs, we've come a long, long way. We try to temper their expectations. Sometimes we need to get tissue in order to help the patient, and that's what the surgery component is. The treatment algorithm is such that for those with constitutional symptoms of fatigue and aching, we can use steroids, hydroxychloroquine, or combination, and sometimes we have to use azathioprine, methotrexate, or mycophenolate. We would rarely need something stronger. With widespread cutaneous disease, antimalarials are the first line, along with corticosteroids. Systemic drugs rarely have to be used for cutaneous disease, but mycophenolate, cyclosporin A, azathioprine, methotrexate, and belimumab can be used. And for those who have digital or cutaneous vasculitis, we may have to be more aggressive with immune suppressive regimens, sometimes being more quick to use methotrexate, mycophenolate, Cellcept, or even intravenous cyclophosphamide.